So we're going to talk about post-operative recovery. Well, first of all, I think post-operative recovery is obviously planned well in advance, and there are very important protocols that all hospitals have in place. And an awful lot of hard work goes on between all the professionals involved in your care: nursing staff, physiotherapists, occupational therapists, and of course the medical staff. But the most important factors are obviously to make sure you've got enough fluids, so it's likely that you'll have a drip. Obviously to control pain, you will have a spinal or sometimes an epidural in place, and supplemented with analgesics. And there are different thoughts about what the analgesic range should be. We quite commonly use a PCA, a patient-controlled anaesthesia, which is a pump attached to a drip, and you can control your own analgesia on demand. So you can push a button and it will deliver a dose of morphine or something similar to morphine. So if you feel pain, you push the button, you have your morphine. So you think, this is great, I want one for daily use. That is illegal, let me make it clear that's illegal. But it's also safe, this button, because you can't overdose yourself, because the machine is programmed so you can't give yourself too much morphine. Now, some surgeons are moving away from the PCA because the effect of this high-dose narcotics, if you like, or the narcotics, can have a side effect in its own right. And there are trends moving, trying to reduce narcotic use, and indeed using different anaesthetic techniques, and using more local anaesthetics which have a shorter acting time but cause less hangover time, and how you use combination of other agents to supplement pain relief. But pain relief, quite clearly, is a story in its own right. So fluid control, pain relief, and then of course just basic nursing care and eventually mobility. Now again, there are different ideas on this. We're moving towards enhanced recovery, and indeed with the right setup, with the right analgesia regime, it is possible to stand up and walk on the day of surgery. I think that's probably unusual in the UK at the moment, but it may become more common. And we usually delay mobilisation until the second post-operative day. At first, it may appear to be quite difficult. There's a lot of anxiety and nerves about being able to stand up and get out of bed. You'll be seen by the physios who will assist you getting out of bed in the correct fashion with the correct amount of safety. Standing, walking onto elbow crutches quite commonly, and then gradually improving in that direction. Now again, the physiotherapy protocols and the speed of recovery does differ quite significantly, and certainly we're trying to move down to 3-day length of stay, which is possible, but more commonly at the moment I think a 5-day length of stay is more common in the UK. So first day out of bed, second day with assistance, often with two, second day out of bed, hopefully going by yourself, maybe walking down the corridor, and the third day post-op, walking down the corridor, and hopefully taking instructions from the physios how to use stairs. That would be a very good recovery, safe to go home around about 3 days, and that's quite possible in a fit, healthy patient with no other factors, and is becoming, I think, will become more routine in the UK. But that doesn't always happen, and often these timelines are stretched out, so maybe discharge around about the 5-day mark. Now there are other issues to consider. There's different philosophies and the sort of advice about home aids you need, whether you need various assistance to go to the toilet, raising the toilet seat and raising various amounts of furniture at home. And these are often put into place with one aspect really, and that is to reduce the dislocation risk. Now again, I think there are more conservative views on this, and this is not always the case, and it's quite surgeon and institutional specific. And indeed, patients are assessed on an individual basis. There may be obviously some specific needs that patients will have to be considered for. But certainly at the moment we're still considering using some of these aids to facilitate the comfort of the patient when they initially go home. Hopefully going home now in the car, there's no need for an ambulance or special facility. You should be able to get in any suitable motor vehicle. You'll be shown how to do this by the physiotherapist. Obviously some anxiety going home, but once you're through the door, become familiar with your surroundings again and feel quite confident on the crutches. Just taking it steadily for the first few days, not having any accidents or falls, stooping down and dislocating or falling. I think it's all very intuitive, this. and just taking your time in terms of recovery. And then gradually increasing your mobility. Normal practice is to try and get off 2 crutches onto 1 crutch by 3-week mark, and then after 6 weeks maybe off walking aids altogether. Now clearly there are patients who can rehab a lot quicker than that, there's no doubt about it. And not unsurprisingly, sometimes patients take longer depending on the preoperative condition. However, I personally prefer a slightly more conservative approach. I think you can sometimes go a little bit too quickly too soon, and you gain very little from it apart from an accident or an adverse event, and a fall could lead to a periprosthetic fracture or a dislocation. So I prefer a common sense, fairly conservative running over the first 3 to 6 weeks. But I encourage you to be mobile at home, getting up, going, moving around to reduce the risks of DVT. You may have been discharged on an oral agent or an injection to reduce DVT risk. You may indeed have some stockings to actually, again, reduce the blood clot risk. But moving around the house and going outside and walking 2 or 3 times a day, several hundred yards to get your circulation going, get your muscles going. But that sort of activity in the first 6 weeks. It's usually common practice, but not always, to be seen by the doctor or nursing assistant or arthroplasty care practitioner to have a wound check around about the 6-week period. Indeed, the district nurse may have checked the wound at home for you, or your GP surgery. But at 6 week, an assessment, how are you generally, any anemia or any other conditions, the state of the leg, the state of the wound, any particular needs, are there any problems? It's usually a fairly quick routine check. Normally giving instructions on that stage to go into the second phase, increasing mobility, being more adventurous, maybe going back to the gym to do some light exercise. And the sort of things I personally tell patients I'm happy to do if everything's going well at 6 weeks is to go to the gym up to 3 times a week, to exercise up to 30 minutes, but without exercising against resistance, just to get things going. And the sort of gym devices which I think are fairly user-friendly, a cross-trainer, exercise bike, and swimming. These are all good exercises. I would discourage using a rowing machine because I think it puts too much flexion on the hip, and there may be a slight risk of dislocation, and indeed growing pain from the increased flexion. But that's a personal view. And no impact loading of the hip, just nice cyclical movements of the hip joint. At 12 weeks, it may be a visit back to the hospital to be checked by a specialist. And at that time, if everything's going well, a slow progression then onto normal activity. So in my practice anyway, that's a sign where you can be more progressive in terms of exercising against resistance and building up some stamina. But the whole rehab program is quite variable. Now, many patients say, will I need physiotherapy? And they're quite surprised that they don't receive physiotherapy. And again, most of the physiotherapy is whilst you're in hospital, advising you about what's safe, crutches, how to move, how to avoid dislocation. And it's unusual for most patients to need physiotherapy, but they simply have this sort of advice so they actually look after themselves, because the whole principle in the early weeks after replacement isn't put them through a boot camp type environment. It doesn't really get you very far in most cases, but again, it is possible to do that. There are some rapid track rehab requirements, but again, a bit controversial as to whether they're necessary. So I really sum up the rehab into 3 parts. One is obviously in hospital. The second part is up to 6 weeks going home, and it's just be sensible, you know, no pottering around the house, going outside, preventing blood clots, but not doing too much. Round about 6 weeks, stepping it up a little, more independent, off walking aids, going to the gym, nice cyclical activity without too much resistance, and then after the 3 months, building up to normal activity between 3 and 6 months.